Hi, my name is Anushka, and today I will be talking about exposure therapy, including what it is, its development, and its clinical utility. Exposure therapy is a treatment modality that is rooted in cognitive behavioral therapy, or CBT. As you may already know, CBT is based on strategies that specifically target cognitions and behaviors. An example of a more cognitively focused approach is cognitive restructuring, while an example of a more behavioral approach would be exposure work. CBT is considered the gold standard for treatment of anxiety disorders, but there is mixed support in terms of the cognitive components of the treatment being independently effective. Exposure therapy is an evidence-based practice used to treat anxiety disorders, obsessive-compulsive disorders, and trauma and stress-related disorders. It is best described as a repeated approach towards a stimulus that provokes fear. There is variability in terms of therapeutic approach to exposures. A graduated approach involves completing least difficult to most difficult exposure tasks, while an intense approach initially targets more difficult exposures. Some exposure approaches implement cognitive and somatic coping strategies to reduce anxiety during exposures. Cognitive strategies include distraction and discounting unrealistic beliefs. Examples of somatic methods include progressive muscle relaxation and deep breathing. Exposure therapy is effective in several ways. First, exposure can weaken previously learned associations between feared stimuli and negative outcomes. Exposure also increases self-efficacy by helping clients learn that they are able to both confront and manage their anxiety. Through exposures, clients can adopt new, more realistic beliefs about a feared stimulus and can become more comfortable with their experience of fear and anxiety. Exposures can be categorized into a few different types, including imaginal, interoceptive, in vivo, and virtual reality. Imaginal exposure requires a client to vividly imagine a feared stimulus. For example, a client with PTSD might be instructed to recall and describe details of a traumatic experience. Interoceptive exposure requires a client to purposefully induce the physical sensations that provoke fear, but the physical sensations are ultimately harmless. For example, a client with panic disorder might be instructed to walk up and down a few flights of stairs to simulate the physical reactions that they might experience during a panic attack, like an increase in their heart rate or an increase in their sweating. In vivo exposures involve directly facing a feared stimulus in real life. For example, a client with social anxiety might be instructed to play piano in front of a crowd of people. Finally, virtual reality exposure uses technology to create a mock environment or stimulus that provokes fear. Clients are immersed within a computer-generated simulation or virtual environment that automatically readjusts to their head or body movement. A client who is fearful of flying in airplanes might use virtual reality exposure therapy to immerse themselves into a virtual environment that resembles an airplane. They can engage in exposure to the feared stimulus, which in this example would be flying in an airplane, without actually having to book a ticket and board a real flight. As I previously mentioned, exposure therapy is clinically useful for the treatment of fear-related disorders, namely anxiety disorders, including specific phobias, post-traumatic stress disorder, and obsessive-compulsive disorder. Exposure therapy for anxiety involves systematic and repeated confrontation of phobic stimuli. Exposure therapy was traditionally limited to particular situations, like engaging in social encounters for people with social phobia, increasing distance from home for people with agoraphobia, and increasing distance from the ground for people with acrophobia. Exposure work was more gradually used to treat other anxiety disorders, but only after identifying the primary focus of concern. For example, exposure therapy was used to treat feared bodily sensations associated with panic disorder, or images of catastrophes associated with generalized anxiety disorder. For post-traumatic stress disorder, exposure is intended to supersede maladaptive avoidant coping and process trauma so that the recollection of the traumatic event is no longer emotionally arousing. Behavioral aspects of treatment typically involve reliving the trauma via imaginal exposure. The process of using exposure therapy to treat PTSD begins first with gathering information about a client's feared internal and external cues and their perception of the fearful consequences and avoidant behaviors. Next, the treatment rationale is provided to the client. Treatment rationale emphasizes fear conditioning and involves psychoeducation around the role that avoidance plays in maintaining their distress. The treatment rationale should also highlight the importance of exposure therapy as a way to get used to the emotional reactions and enable cognitive changes so that feelings of danger are not so readily perceived by the client. After that, the therapist and client collaboratively identify scenes for imaginal exposures, as well as situations for in vivo exposures. The goal is to help a client learn a few things. First, exposure therapy helps them learn that situational reminders of their trauma are not the same as re-experiencing the trauma. Second, they learn that anxiety does not remain indefinitely in the presence of fearful situations or memories. Third, the client learns that anxiety does not lead to a loss of control. Exposure therapy also effectively treats obsessive compulsive disorder, or OCD. In the early 1970s, behaviorally oriented researchers began to apply learning-based treatments to OCD. These treatments involved helping the client in distress to confront stimuli that provoked their obsessional fear and refrain from ritualistic behaviors that served as an escape from that fear. Exposure for OCD treatment involves gradual exposure from the least anxiety-provoking situation to the most anxiety-provoking situation. Hierarchies of fear-provoking thoughts and scenarios are collaboratively determined by the therapist and client, from the least distressing scenario to the most distressing scenario. The therapist and client work together to approach each of these tasks, working from the easier exposures to the more challenging ones. Exposures conclude with very demanding tasks that extend beyond normalcy. For example, a client with contamination fears might create a hierarchy that would gradually progress to tasks that seem more and more disgusting to the client. These activities could be things like touching doorknobs in their home, touching money, touching sweat under their armpit, touching the doorknob of public restrooms, and then graduating up to placing their hand on the seat of a public toilet, touching a paper towel dampened by their urine, and maybe the ultimate exposure of finally holding a piece of toilet paper that contains their own fecal matter. While completing these tasks, the client is to minimize their attempts to maintain cleanliness and is instructed to focus on their worries or distress rather than avoid their distress. Exposure therapy has been identified as a first-line treatment for anxiety disorders by the American Psychological Association and the National Institute for Clinical Excellence. Despite being an empirically supported treatment, many clinicians do not utilize exposure therapy when treating fear-related disorders. A primary factor contributing to the underutilization of exposure therapy is ethical concern held by therapists. An article by Olatunji and colleagues discussed and challenged several common critiques of exposure therapy within the greater context of the ethical mandate to do no harm to clients. The main critiques addressed by Olatunji and colleagues include attrition rates, symptom exacerbation, patient preferences, and litigation and ethical complaints. One critique of exposure therapy is that it must lead to high dropout rates amongst clients, since it involves confronting seemingly intolerable stimuli or situations. One study by Hembry and colleagues noted that outcomes from 25 different clinical trials found no differences in attrition rates between prolonged exposure, exposure with cognitive therapy or anxiety management, and eye movement desensitization and reprocessing. Another concern regarding exposure therapy is its perceived potential to exacerbate symptoms, especially for clients with PTSD. A study by Foa and colleagues examined this by studying worsening of symptoms among people treated with prolonged exposure. They found that a minority of individuals experienced temporary symptom exacerbation at the beginning of imaginal exposure, but the majority of clients with PTSD did not experience symptom exacerbation at all. Some clinicians are fearful that exposure therapy is not favored by clients, but according to Deacon and Abramowitz and Norton and colleagues, Anxiety patients perceive exposure-based CBT as more acceptable and more likely to be effective in the long term compared to psychopharmacology alone. Additionally, among clients receiving CBT for panic disorder, in vivo and interoceptive exposure are perceived as highly useful despite their lower ratings of likability of treatment. These findings suggest that common therapist reservations about exposure therapy being undesirable or unethical are not shared with those who receive exposure therapy use treatment. Another issue is that some therapists raise litigation and ethics-related complaints regarding exposure therapy. Oftentimes, therapists will conduct exposures outside of an office setting to help generalize their clients' skills to the real world. Some therapists, however, are concerned about the out-of-office nature of exposure work and fear that this could lead to an inappropriate dual relationship with their clients. Other clinicians worry about being sued for malpractice if their client decompensates during an exposure. It's important to consider, however, that exposures provoke anxiety that is no different than what anxiety disorder patients are already experiencing. Exposure also provokes anxiety that is part of the body's natural defense response to anxiety-provoking situations, and therefore exposure is not inherently dangerous. According to studies by Richard and Gloucester, not a single instance of litigation related to exposure therapy was found. For more information on the articles I referenced in this lecture, please take a look at the references provided at the end of this video. This concludes my lecture on exposure therapy. Thanks so much.